live on YouTube, and
live. Let's start the webinar now, yes?
yes, please. Preeti, because I'm on full screen, so I can't see. Can you see how many participants have entered?
I've got 500 in here.
Okay, perfect. Ranjan, can we get started? Hi, Ranjan. Ranjan, are you on mute?
Yes, is the answer.
Yeah, okay. Shall we start?
Yeah, perfect.
Okay, so welcome to everyone to this webinar series, principally organized by Dr. Murali Verma, and who's assembled a stellar array of pathologists from across the world, who I'll introduce to you in a moment. And the topic really is that of macroscopy, and he's euphemistically framed it as macroscopy under the microscope, a critical reappraisal of grossing practice. I think this is a really important aspect of the function of pathology and us as pathologists. Oftentimes it is delegated to others, and it is now become something of a infra-dig practice amongst pathologists. And so we hope to tease apart the aspects of grossing across several subspecialties. And this is a great opportunity for the audience to participate and pick the brains of specialists as to what is ideal practice. So I'd just like to acknowledge that, as I mentioned, Dr. Varma had assembled a team to produce a seminar within the Journal of Clinical Pathology, and this is in the March issue. And this is a companion to those several articles that have appeared there. They are free to view and will be in perpetuity. We'd also like to thank the British Association of Urologic Pathology and the British Association of Gynecological Pathologists, under whose auspices this seminar is being performed. We've got several topics, and just to remember that for each of these sessions, it requires individual registration. And these are some of the areas that were covered in the papers in the Journal of Clinical Pathology, and the reference is down there at the bottom. This is the program, and as I mentioned, separate registration is required for each session. And what I'll do is I'll quickly introduce you to the panel who will be discussants this morning. We've got Dr. Murali Verma from Cardiff in the UK, who is our principal speaker this morning. And the progenitor of this particular webinar series, we've got Professor Neil Shepherd, a GI specialist from the UK, Dr. Paramita Roy from Calcutta in India, who will be representing GU. We've got Dr. Vikram Deshpande, a GI pathologist in Boston, Professor Dipti Karamchandi, who is in Dallas in Texas and is also a GI specialist. Dr. Monica Vyas, another GI specialist who's in Boston. We've got Professor Laura Collins, who's in Boston, a breast specialist. Dr. Jason Wong, a gynecological specialist in the UK. Dr. Karen Talia from Australia, who is representing gynecologic pathology. And then we've got Dr. Pring, who is head and neck. Dr. Khan, also head and neck, and Dr. Jones, head and neck. At this juncture, I'd like to remind the audience that for the Zoom participants, you need to fill in the Q&A box, and those who are viewing via YouTube, it's the chat box. And again, a reminder that all times are Greenwich Mean Time and not British Summer Time. Just to remember again that your participation is critical. It's a great opportunity to pick the brains of our assembled consultants, and please do enjoy, and I'll hand over to Dr. Varma to make his presentation.
Thanks, Ranjan. Thanks very much for the introduction. Welcome all. Thank you for taking the time to attend the session. I hope this will be both interesting and entertaining. So what we are talking about is a critical reappraisal of macroscopy techniques. Now, this basically, as Ranjan said, the background to this is this paper that was published in the Journal of Clinical Pathology, which has got the details. I wouldn't have the time to go through all the details in here, so I'm going to pick up bits and pieces of it for discussion. Let me say that I've never been short of an opinion, okay? And today I'd probably be even more opinionated than usual. But my opinion, I'm giving you my opinion based on my experience in reasoning. And I think I probably will be provocative and probably controversial. And I make no apologies for that. I think it's important for us to discuss and debate these issues. And it is perfectly okay to disagree. And in medicine in general, pathology in particular, and I suspect GU pathology especially, it's very common to have diametrically opposite opinions from experts. So we've got these two large expert groups in GU pathology that publish conflicting recommendations. So what do you do with it when you have these diametrically opposite opinions? Clearly, if your opinion is diametrically opposite to mine, I know that my opinion is right. It's always right. So your opinion has to be wrong. No, I think that's wrong. That when we have diametrically opposite opinions, it's important to recognize that both can be right. So let me demonstrate that to you with a small mind experiment. So what's the color of this apple? Well, let me tell you, this apple is not red. This apple reflects light with a frequency of about 430 terahertz. That's what Google tells me. And so it is perceived as red by most of us. But if you have a colorblind person, this apple could be black or green, depending on the type of colorblindness, and they are just as right as I am when I say it is red. So we can have different opinions because we are looking at it from a different focus. So different perceptions, different focus. And it comes back to that. So in this webinar series, we are not trying to teach you how to do a cut-up. So we are trying to get to discuss and to understand some of the issues with macroscopy. Let me start with my first really provocative sentence, is that evidence-based medicine should never be based on evidence. It should be based on good evidence that has been critically appraised, not just any evidence. And I'm afraid when it comes to macroscopy, a lot of it is not evidence-based. So I like this. This is one of my favorite quotes from Christopher Hitchens about what can be asserted without evidence can be dismissed without evidence. I think this is relevant because a lot of what I tell you quite reasonably, you would come back to me and say, Murli, where is your evidence for what you're telling me? And my reply to that is our current practice is not evidence-based. There is zero evidence on all these recommendations of X number of blocks per centimeter of maximum diameter of the tumor. So that's not evidence-based. So we can make those changes without evidence based on reasoning. So let's talk about macroscopy. We all know that it is a cornerstone of pathology reporting. And if you got something that is missed on macroscopy, it doesn't matter whether you've got Professor Shepard looking at the slides from the other end. He can't diagnose a tumor which has been missed by his trainee on the cut-up bench. It also provides documentation of what was removed. So whether the ovaries have been removed, the cervix have been removed, that is a permanent documentation which is provided by the microscopy, even if the sections have not been taken. So I think I find it extremely useful to compare macroscopy and microscopy. So when it comes to microscopy, the slides and tissue blocks are stored indefinitely. So that means the data can be retrieved much later if necessary. So what that means is if I miss something on microscopy, I can retrieve that data later. If I miss something because my clinicians don't use that data, but the patient then goes to London and the urologist in London needs that data, the London pathologist can review the histology slide and retrieve that data. Same way, if I don't do immunohistochemistry up front, I can do the immunohistochemistry after the MDT or the cancer board meeting. So you have a second chance. But when it comes to macroscopy, it's often a single window of opportunity. Because if I don't record that data and the specimen has been discarded after the case is reported, I cannot go back to get that data. If I haven't taken the right number of blocks or either the right number or from the right area, I cannot go back and take more sections after the specimen has been discarded. So with macroscopy, it's critical that we get it right the first time. So, and there are times when accurate and complete collection of macroscopic data is probably more critical than accurate and complete collection of microscopic data. That doesn't mean microscopy is not important, but I'm making the point that macroscopy is at least as important. And there are times when macroscopy is more important than micro. So whether in a specimen there is one tumor or two tumors, you can't say that from microscopic. It is a macroscopic one. If a tumor is larger than the size in a slide, it is a macroscopic size that is important. Same way, the distance from the margin, if it is greater than what is on the slide, that becomes important. So in these situations, the macroscopic data is actually more accurate than the microscopic data. So what that means is that good macroscopic examination requires complete knowledge of the final reporting requirements. So if you're somebody who is doing macroscopy and is not aware of what the final report looks like and what is required, then it's very, very difficult to do a good macroscopic examination. So let me give you an example. So when it comes to tumor staging, renal cell carcinoma, if you have renal cell carcinoma in the upper pole directly invading into the adrenal gland, that would be PT4. If it is a discontinuous involvement, it would be considered metastasis, PM1. And this is critical because if it's PM1, the patient would get adjuvant therapy. So this is clinically critical, but you can't do it with microscopy. So I've shown you a slide of an adrenal gland with a renal cell carcinoma in it. I can't say whether this is direct invasion or discontinuous invasion. That is a macroscopic assessment becomes critical. So this distinction may not be possible for microscopy. So again, I'm trying to emphasize how important macroscopy is. And if you want to do good macroscopy, you also need to know the clinical requirements. So let me give you an example. I've got this testicular tumor. It's got a very fleshy appearance, very homogeneous appearance. It looks like it's probably a seminoma. But the AFP is raised. So that means the patient is likely to have a non-seminoma. So how hard should I search for a non-seminoma? Do I need to all embed this tumor to look for any non-seminomatous component which could change the management. Now, the raised AFP suggests a non-seminomatous component. And if you look at the clinical side, if the AFP is raised, then the patient will be treated as a non-seminomatous. So even if the pathologist reports it as a pure seminoma, the oncologist will manage the patient as a non-seminoma. So if a non-seminomatous components cannot be identified histologically and the patients have elevated AFP, they should be treated as if they have a non-seminomatous germ cell tumor. So it doesn't mean necessarily that they would give treatment, but the follow-up protocol would be like a non-seminomatous tumor. So it is not critical for the pathologist to detect the non-seminomatous component. So extensive sampling is not necessary. So if the dissector is aware of this, he would not bother to take too many blocks. If you're not aware of this, you might end up with a lot of unnecessary sections. So you need to know both the final reporting requirements for the pathologist and the final clinical requirements. Yet, macroscopy is often delegated. I hate to say relegated, but it's certainly delegated to less experienced operators, and most critically, with often very limited guidance and supervision. Let me make it very clear. I have no problem with who is doing the cutup. So whether the grossing is done by medical staff, non-medical staff, pathology trainees, consultant pathologists, it doesn't matter, provided the person who's doing it is well-trained, has the guidance, has the, is able to get the help where necessary. But I think macroscopic examination is both undervalued and I think it's insufficiently discussed. So when you go to these meetings, the big meetings, the ASCAPs, the ESPs, the PathSocs, how many lectures do you have on macroscopy? You generally have a few slides here and there on macroscopy. The accent is always, the stress is on microscopy. I think we need to change that. So which is what we had highlighted in an editorial in histopathology, that we need to look at this more carefully. And this was then expanded in this review paper in the Journal of Clinical Pathology. So essentially, if you're going to prevent errors, we need the person who is doing the cut-up needs to understand the rationale behind the protocols, not just blindly follow the protocol. Because if you understand the rationale behind the protocol, then you would be able to identify exceptions to the rules where you don't need to take extra sections. If I've got an ovarian tumor with a patient has metastasis, maybe I don't need a lot of sections because I know the patient already has invasive disease because she's got lymph node mets. And the other thing is we need probably more supervision and guidance for less experienced operators. Just one point, please don't raise your hand, those who are attending. You need to put your questions into the Q&A. So I'm going to take a break over here and invite the expert panelists for their opinion on this, on the issues that I have discussed. I would request the panelists to raise their hands, and Ranjan will then moderate the discussion. Right.
I think proceed.
Right, Paramita?
Hello. I all excellent points, Dr. Verma. Are you able to hear me?
We
Yes,
can.
perfect.
Yeah, go ahead.
Yeah. And one more point I wanted to add was when we apply the guidelines, generally all come from the Western world, and the amount of sectioning, the protocols that we are supposed to follow is very, very difficult to establish in India or countries like that. And here we generally have trainees for doing the cut-ups. So they don't have the training during their postgraduate training. So they're learning on the job when they come to, when they're given this job of grossing and are expected to follow these data sets. So there are errors of very, very gross errors of all kinds. And and some of the data is redundant. Like you said, our clinicians don't use it, will never use it. They don't have ability to use it because of the kind of patient profile that we have. So I think continent-based or country-based modifications, which are more standardized, are important. And we don't have PAs, so and the trainees are a rotating batch. So by the time you finish training one lot and they come up to stand, they are gone, and you're back to square one. So that's another challenge.
You make some very, very good points. I think they are very relevant points. I think, and these are very serious issues, because one of the problems we have, with pathology training, we wouldn't let a pathology trainee report a microscopy, a report, until they've got their exams, or it's very late into their training. While we let them do macroscopy independently after about a few weeks of their training. And that, I think, is an issue. So again, it's not a problem for them to do it independently, but they should have both supervision and guidance. So that is critical. The other point you make is even more important, the fact that we have this standardization. As pathologists, we are very much into standardization. Now, if I look at my clinical colleagues, in the UK, we have the NICE guidelines. In GU, we've got the European guidelines, we've got the NCCN guidelines. But every single clinical team that I know have their own local guidelines. It would be based on the NICE guidelines, the EAU guidelines, the NCCN guidelines, but they would always make their own guidelines for their own. But in pathology, unfortunately, we have a standardized system. So often I'm reporting things that a urologist in London or New York may require, but a Cardiff urologist that would not use at all. And that, I think, is a very valid issue. Monica?
Okay, Monica, yeah.
Yeah, thank you so much. So, hello, everybody. And I just wanted to mention a point that here in the US, particularly in the post-COVID era, we're facing a acute shortage of, histotechs and lab staff. So we are definitely strained for resources. And currently in our department, at least, we are in a process of reviewing our grossing SOPs and guidelines to see how we can minimize the burden on our lab without actually compromising patient care. So, and I think this is a real opportunity to, go back and relook at, as you said, evidence-based guidelines, or even come up with our own evidence. Because I feel like when you're channelizing your lab resources excessively towards one patient, you're actually taking away care from another patient, delaying care of other patients. So that is really counterproductive. So I just wanted to see what other panelists have experienced, or in general, what the experience has been across the globe about this.
Again, very good point, Monica. And I think, again, sometimes it becomes a double whammy. When we have less experienced people doing the macroscopy, they tend to take more blocks because they're not sure, they play it safe. And when they take more blocks, it burdens the lab even more. So it becomes a vicious cycle. Yeah, I think that's a very good point.
Dipti?
Yes, Murali, you bring up some very good points. So thank you for that. And Monica, I agree with you. I mean, I think it's all over nationwide that we have this shortage of, these experienced personnel who would help us grow. And moreover, there is such fast turnover time. It feels like, you train some, and the moment they are trained, they leave. That's another thing we are dealing with. I actually had a question for the panelists. How many of you actually take photograph on gross resections of cases? Is there a protocol all malignant cases? Or it's all in our institution, I'll tell you, we take gross photographs of all colorectal resections, but everything else pretty much is PA resident dependent. I mean, it's totally on their discretion. Sometimes they'll take pictures of some cases, which we don't even need. Not that we don't need it, but we can do without. But sometimes there are cases in which we are okay, we should definitely need a picture, but that is not photographed. So just curious to hear what is the protocol?
Can we take this bit later? Because I will be talking about it later in the presentation. So
Sure.
maybe we can, it's a very valid point, but I think let's discuss this when I talk about that section.
Okay, got it.
Neil, go ahead.
I just want to emphasize something that Murali said about standardization, because I don't think standardization happens. And certainly in the UK, as you intimated, Murali, all departments have SOPs, standard operating procedures, for the macroscopic assessment of every single specimen they receive, but it doesn't happen. People don't follow their own SOPs. And in my article, which hopefully some of you have read, which was written with Vikram's approval, was written a little bit with my tongue in my cheek, and going along with something you said, Murali, in your article, that I think you can make a strong argument that block keys on appendices and gallbladders means the specimen has not been assessed standardly. And I do not have a block key for those specimens because I say they should be assessed and blocked standardly. And I would make the same argument. I don't know whether Dipti will agree with me or Ranjan. I'd make the same argument for colorectal cancer specimens. Why do we need a block key? Why aren't they done standardly like our SOP tells us to do it? I have a little bit of a thing about, and I think you do a bit, Murali, about report contamination. That reports should not be contaminated with stuff that our users don't want to see. I do say at the end of my thing that perhaps I'm pushing my luck by suggesting we shouldn't have block keys, and I think there are some cases I got a bit of a hammering from one of my actually uropathological colleagues locally for suggesting that, but there is an important point here that we should standardize the way we take things, and therefore we don't necessarily need a block key because that suggests we're not standardizing.
I think Neil, it's a valid argument. But I think also there's one other thing I would add to this is that does the block key need to go in, even if we have a block key, does it need to go to the report that goes to the clinician? We could have it in the path system, but not in the one that goes to the clinician. And so if somebody is going to review the slide and you're sending them the slide, you send them the path version of the report, which includes a block key. But the one that you have on the clinical notes doesn't need to have because the block key is useless without the slides. The block key is important when you're reviewing the slides in some cases. I agree with Neil that in the standard cases, they're probably less important.
Dipti?
Yeah, so again, coming back to Neil's point, I mean, yes, in standard cases like appendix and gallbladder, we probably do not need it. But I think like majority of like say tumor cases, they always, not every tumor is same. So I would argue that, we would need the block key just because, every sort of tumor is different. So although we do have a standardized protocol, but just because, every tumor, every case is different, there are chances that we might not be able to follow the standard SOP on like all sort of same resections, if that makes sense.
What's your response to that, Neil?
I think Dipti's absolutely right, and there is another important point, isn't there? Is that when you're reviewing cases, and obviously Dipti and I probably do quite a lot from other places. That all you've got is the report, and then you do need. I'm just being a little bit cynical by suggesting that we don't need the block key. I think the much more important point is that we have SOPs, and we should be using those SOPs and standardizing the way we do things, particularly for the common specimens, as Dipti and I have said, appendices, gallbladders, those specimens.
Yeah, I agree.
And I would add colorectal cancer resections as well. I think, but I would suggest they're pretty standard, but there are undoubtedly specimens where a block key is essential, and particularly for those external reviews.
Right, Roger, can I make, so some of this, I think, as we discussed, there will be a lot of things that will be covered later. So maybe, if we go ahead with this, and then we can probably cover the rest, I think some of these will flow better.
Okay, and we've got questions related to this from the participants as well. So press ahead.
Okay. So let's talk about specimen handling. So what is the first step when it comes to specimen handling? The first step is fixation. It's absolutely key for specimen handling, particularly when you got peritoneum-lined specimens, because the peritoneum forms a barrier for penetration of the formalin. So that's like specimens like the testis or the uterus. if you do not slice them, they will not fix properly. There is this misconception that tissue fixes at the rate of 1 millimeter per hour. That is incorrect. It is formalin penetrates at the rate of 1 millimeter per hour. And then you need to get the various things to occur for fixation, like the cross-linking, etc., which would take much longer. So serosa and myometrium, they form a barrier to formalin. So they will slow down. So if you don't slice a specimen, they are going to cause delays in the actual specimen fixing and autolysis. And because cross-linking takes longer, small biopsies also need adequate time for proper fixation. So it's not that because it's only a tiny biopsy that it be fixed in 5 minutes. No, it's still the process of cross-linking, etc., will take time. So when it comes to specimens like the uterus and the testes, prompt slicing is critical. So let me demonstrate some of these to you. So like in the uterus, if the uterus is not promptly sliced, you could get retraction artifacts, which can mimic lymphovascular invasion. And we know that lymphovascular invasion is a significant risk factor for endometrial carcinomas with very significant management implications. And the important thing here is that if you've got a poorly fixed uterus, you can get pseudovascular invasion, the grading can be compromised, and then even your fancy immunohistochemistry or molecular tests the results will be compromised. And most important of all is that this cannot be rectified, or it's very, very hard to rectify. So once you've messed up at the fixation stage, it's very, very difficult to correct it later. So here's an example of an endometrial tumor. It looks very nasty. So is this undifferentiated endometrial carcinoma? Now, the immunoprofile of an undifferentiated endometrial carcinoma would be immunonegative for several markers. But in this case, this was delayed fixation with autolysis, and all your markers could end up false negative because of the fixation problem. So it is a potential pitfall. I'm not saying that this will necessarily happen, but when the specimen is poorly fixed, there is a risk of this patient being misdiagnosed or the parameters being wrongly interpreted, and the patient could end up getting unnecessary chemotherapy, all because the specimen was not fixed to start with. Here is a testicular tumor. So you got this area in the testicular tumor, the cells look pretty nasty, they look syncytial. You certainly start thinking about endometrial carcinoma, embryonal carcinoma. And the reporting pathologist quite reasonably did all the immunohistochemistry for embryonal carcinoma, which it turned out it was not embryonal carcinoma, it was seminoma. This was essentially, again, a very poorly fixed specimen. So all this was pure artifact. Now, if you look at the well-fixed part at the periphery of this specimen, it was clearly a seminoma. But because the fixation was poor, because you had autolysis, the reporting became much, much more difficult. So prompt slicing is critical. Now, this is where I think I do have, an issue, or many of my colleagues have an issue with me, because I strongly feel that we should try to educate surgeons to slice specimens like uteri and testes in the theater, especially if a delay is likely. So if they are doing an orchidectomy and dumping the testes into a big pot of formalin is not going to do anything. If it's going to just sit in that pot of formalin over the weekend, it's going to be autolyzed by Monday morning. It would make much more sense for the urologist to put one single slice to a specimen. Now, often pathologists are very territorial, and they feel that, God, no, we can't let the urologist or the gynecologist handle our specimen. I'm sorry, I think it's much more, the surgeons are highly trained. They do complex surgery. So I refuse to believe that a gynecologist who can do complex oncologic surgery cannot be trained to put a single slice through the uterus, or the urologist to put a single slice to the testes and to prevent a serious misdiagnosis. The other point I would make is do not compromise the assessment of critical prognostic factors that guide adjuvant therapy because you're in a hurry. When a patient has major surgery, like a cystectomy or a colectomy, they cannot get chemotherapy, adjuvant chemotherapy, until they've recovered from that surgery. So a couple of days delay in the reporting is not going to do any harm. But if you get the diagnosis wrong or the parameters wrong, the vascular invasion and the other important parameters wrong, that could have serious impact to the patient management. So do not compromise the final report just to expedite the report. The other reason why you need to proper fixation is for thin slicing. So if you compare an apple and an orange, it's much easier to take thin, even slices of an apple than it is of an orange. And that's because the apple has an even consistency, so it's easy to make thin slices. The orange is floppy because you've got some areas which are thicker, some areas which are more watery. The same thing is true with tissue. So if you've got tissue which is unfixed or semi-fixed, it's very difficult to take thin, even slices. So it's much easier to take thin, even slices of a specimen once it's been fully fixed. So I would strongly recommend fix the specimen properly before you start slicing into it in detail. Now, when it comes to examining the specimen, is it better to examine it? Sorry, I just need to get rid of this floating panel. Yeah, fresh or fixed. And in general, any lesion, whether it is a tumor or a lymph node, anything is better felt in a fresh specimen because rest of the specimen is soft and the lesional area, like the tumor, would be firmer. So you can feel it much easier in a fresh specimen. Once you fix it, this differential in the consistency between the tumor and the background becomes less. So it becomes more difficult to feel the specimen in a fixed specimen. On the other hand, in a fixed specimens, the lesions are often better seen. So the lymph nodes or the tumor are better seen in a fixed specimen than in a fresh specimen. So this is particularly true in lymph node dissections. Should we dissect lymph nodes in a fresh specimen or a fixed specimens? So lymph nodes counting, they're definitely more, the counts are more reliable if you do it in a fresh specimen. Let me demonstrate this to you. Now, this is a pelvic lymph nodes, and as pelvic lymph nodes often are, they are very fatty. So pelvic lymph nodes often have a central fatty bit and some lymphoid tissue at the periphery. So here you can see this is clearly a single lymph node. You can see the subcapsular sinus going around it. Now, if I do this in a fresh specimen, I would be able to feel this as a single lymph node, and I would report it as one lymph node. If I deal with this in a fixed specimen, I would take one slice to the top, which will seem to be a lymph node. Other slices would seem like to be just fat, and the slice at the bottom would be another lymph node. And I'm very likely to count this as two separate lymph nodes. Same way, if I got a lymph node which is irregular in shape, so when I take a slice, the single lymph node may appear as two. So it can be very difficult to know whether, when I've got two lymph nodes which are close to each other, whether this is one lymph node or two lymph nodes. So fixed specimen dissection, most of us, including me, we generally do lymph node dissection in a fixed specimen because it is neater, cleaner, easier. It's more convenient. But we have to accept that when we dissect it in a fixed specimen, overcounting of the number of lymph nodes, especially the total number of lymph nodes, is entirely not reliable, and it's inevitable that you will overcount the number of lymph nodes. I used to tell my urologist in Cardiff, he had an excellent wine cellar, and I used to tell him that the number of lymph nodes that I would report would be directly related to the quality of the wine that you provide me for Christmas. Right? I can make make any number of lymph nodes by simply the way I interpret the lymph nodes. And this is not just me. There are multiple studies out there showing that there is significant variation in the lymph node counts. And so I personally, I'm not a great fan of surgeons using the lymph node count as an indicator of their quality of the surgical technique, because I think there is far too much variation, both from the technical side about how we process the tissue, as well as the interpretation side as to what constitutes a lymph node. There's too much variation among pathologists to make this a reliable indicator of surgical quality. Again, I'm going to pause over here and take any questions. So if there's anything for discussion. Right, Deepti?
Okay, Deepti, yeah.
Okay, so Murali, I mean, I have mixed opinions about surgeons slicing the specimen in the OR before they send it to pathology. I mean, I agree they can do complex oncologic resections, but I'm not sure if I'm confident, number one, of their handling the pathology specimen appropriately once it's out of the body is my one concern. I mean, I have seen specimens being cut right through the tumor, like for colorectal resections before they come to pathology. But the other thing is that, once the surgeon takes out the specimen, there is no strict procedure, as in there are residents, there are trainees, there are med students, there are nurses. So I feel like, if you give them okay, it's okay to slice the specimen, I'm not sure, how well or how easy would it be for us to gross once they do that in the OR? So I'm not sure. I mean, on papers, I think it's pretty good, but practically, how do you implement that? That's the challenging part.
Yeah, I think again it comes back to exactly like we talked about, whether it's trainees or any less experienced operator, it's about guidance and education. So again, I wouldn't for a moment say that just tell the surgeon to put a slice through it. No, you will have to explain to the surgeon how you want a slice. And it'll also depend on the specimens. So there are some specimens, as I said, like the uterus and the testes, where it becomes absolutely critical that they are sliced promptly. There are other specimens where it may become less important. Now, in case of the GI specimens, if it is an issue, you got some serosa there, right? Maybe in the rectal one, it may be less of an issue because there is no serosa on one side and the penetration is better. But you could still train the surgeon to only open the GI specimen, excluding the tumor. So there has to be, yes, I totally agree with you that you need that communication between you and the surgeon, the pathologist and the surgeon. But I find it difficult to believe that the surgeons are not trainable. So that's my personal opinion. And the other side, I totally agree. There is no one size fits all. There is no one size fits all for some specimens. It may be easier where you only need a simple slice. Some academic institutions, it might be easier. In some in private practice, it might be more difficult. So I'm not saying that everybody should do it, but it's something that we should not exclude it automatically.
Murali, my greatest fear is that they will take slicing a specimen as seriously as they do filling in the request form, i.e. delegating it to the least responsible person.
I totally agree. So these are things I think you'll have to go, it's horses for courses.
Sure.
But there are certainly specimens where they are trainable. So this idea that, let me put it, and I think let's get Jason in next, because it's about like in the uterus. Now, in the uterus, things like the grade of the endometrial cancer is vastly more important than the margins of an endometrial cancer. So if you compromise things like LVSI and the grade to make sure that your margin status or whatever is not compromised, I'm not sure whether that is right. So again, as I said, I'm sure there will be other opinions, and I'm not saying that is a one size that fits all.
Sure.
But it's certainly one I would like people to
Jason, do you want to pick it up, Jason?
Yeah, I'm sure that surgeons are trainable. As you say, it depends how diligent they are with it when they have other priorities and the patient's still on the table. I think a lot depends not just on local practice, but on the logistics locally. I know some places where the surgery is carried out on one site, including malignant surgery for malignant specimens or tumors, but then the pathology is carried out on a different site. And then there's a delay in transportation. It's in situations like that, you may well want to train the surgeon to open the specimens. However, if the specimens are going to arrive in the pathology laboratory under an hour, for example, their pathologist will be on site to assess those specimens, then perhaps it'll be safer to leave those for the pathologist to do. It isn't just about being territorial, but pathologists like to assess the external aspect of a specimen. For an ovary, you want to know if it's intact or not. For an endometrial cancer, you want to ink the parametria before you open the specimen. So it does depend very much on the situation and how much you trust your surgeons.
Sure. Paramita?
I couldn't agree with you more, Jason. It's not, there is no one size fits all, but it's one that we need to look at. Like, for example, like you said, the endometrium, the uterus, about not compromising the parametrium. We could teach the surgeon to put a cut through the other way, right, where you don't slice through the parametrium. I agree that may not be the ideal way you like it, but at least if it's going to stick, it's better than it's staying in a pot of formalin for a long time over the weekend, or if it's got to be transported. So my point is, we don't necessarily need a one size that fits all or all scenarios. I think we have to be more flexible. What is best for that particular patient.
Paramita?
Yeah, giving again a real world scenario. When the surgeon gives one cut, they just give one cut. In a 16 centimeter breast, then squish it into a tiny bottle with very little formalin. They do no justice to that specimen. And if we get it like after the weekend, it's as good as gone. So when they rush it, when they don't do anything, they know that they have to rush it to the lab. So sometimes I would go with, it's better that they don't do anything. And we tell them to keep it in the fridge. Because if they put it in a bottle, even with a slice outside, it spoils in a hot country like ours if they haven't done that 5 millimeter slicing. And I don't think you can train any surgeon to do 5 millimeter slicing. So we get a lot of compromised specimens when they. Yeah. So when they send it to us fresh, or they keep it in the fridge overnight and send it to us the next day morning, we get the best quality of preserved tissue.
Just a clarification there. I'm not for a moment saying that the surgeon should put multiple slices through a specimen. Okay, like 5 millimeter slices. I'm talking about specific specimens like the uterus, the testis is a classic example. Putting one single slice through the specimen, maybe putting it halfway a slice and then putting a paper or a towel or something in there for the formalin to get in. So I'm not talking about multiple slices. And not necessarily all the slides.
I just feel that when they don't do that, they feel more responsible to send it to the lab within an hour. But when they do that, they feel that they have done justice to the specimen, and we end up having more necrosed tissue.
Yeah, fair enough. So if you've got a situation where you can get your specimens promptly to the lab before 5 o'clock, because often in many UK labs, there are not many people after 5 or 6. Okay.
No, they keep it in the
provided
fridge,
you can get it, that's
they
fine.
keep it in the
but I'm
fridge
talking about
overnight.
the situations where you can't. Sorry, go ahead. Sorry.
So we do have late surgeries, so they keep it in the fridge overnight. And if you put it in formalin, you won't have enough number of specimens fitting in the fridge. When they keep it in the fridge, they stay fine. But if they keep it with one slice outside, they end up spoiling.
So as you can see, this is going to be a very hard sell, right? But I think it's one that all I would ask you to do is to consider it if it can work in your particular situation.
Sure. Food for thought. Now let's quickly go to Neil and then Monica. Neil?
I was just going to follow up on Morali's comments on lymph node harvests. In a series of, say, 50 colorectal cancers, there's only one factor. And I agree with you morally, it's the pathologist or whoever's doing the dissection is the only factor. I sat at a meeting a few years ago where a surgeon was asked, what were the factors that determine how many lymph nodes one gets out of it? This was an axillary clearances in breast cancer, actually. And he said there's only one factor, it's the pathologist who does it. I happen to be the only pathologist in the audience, and he was very kind to me and said, if Professor Shepherd was doing it, then we'll get so-and-so, so-and-so. But I want to take the example of colorectal cancer and the Royal College guidelines. This is nearly 20 years ago. We set the rules for how many lymph nodes you should get as a median in, say, 50 cases. And we've seen a dramatic increase from some hospitals getting a median of about 4 or 5 lymph nodes to getting 25 lymph nodes as a median. And I think that clearly demonstrates that it's all about who does the dissection and how much time bums on seats, basically. This takes half an hour, you accept half an hour. See, we've got a couple of questions actually about highlighting lymph nodes. I don't believe you have to highlight lymph nodes. I think you've just got to, for the colorectum, at least, you just have to take the mesocolon or the mesorectum off the bowel itself. Bacon slice, sight and feel are the most important, but it's all about the time you take to do it. And I think that's the only factor that determines the lymph node harvest.
Okay, then quickly, Monica.
So I just wanted to, make a point in support of Dr. Varma's comment, really. So I know we've all been burned by those curiosity cuts that surgeons make, and then, where we have to sort of do like the patch-up job of sectioning along the same plane that the surgeon has made an incision. And so, and it can be quite challenging and a deviation from our protocols. So it's definitely challenging, but I do agree that surgeons are trainable. And if it becomes a part of their routine, like specimen handling, before they pass off the specimen to pathology, I think it can be something that can be a part of their protocol as well. And I just wanted to give an example that at our institution, for the Whipple resection specimen, surgeons actually do the inking. Those decisions were made before my time, so I don't know the rationale behind them doing that. But if somebody had told me 5 years ago that a specimen will be inked by a surgeon and given to you, I would totally freak out. But they do a fantastic job with it. So I think if they're trained and if they know how to handle it, they definitely would be able to do the job. Thank you.
Yeah. Great. Going to carry on then, Murali.
Okay, let me go ahead. And okay, so what's the first step with microscopic examination? So the first step we said handling was fixation. So you fixed it properly. Now you're going to start your microscopy. So have a think. What should be your first step? So you're going to do you've got a mastectomy on your table, and you're going to start slicing that mastectomy. What should be your first step? Check the indication. The clinical history is critical. At least you should know what the indication for mastectomy was. If the indication for mastectomy was 2 1-centimeter tumors in different quadrants of the breast, and then you slice it up, you sample one tumor, you weren't aware that there were 2 tumors. Now you got a sliced up specimen. It can be very, very difficult later to go and find that second tumor. And if you end up with a report that says only 1 centimeter low-grade ductal carcinoma and the patient had a mastectomy, there's a little bit of a problem there with justifying and that can be avoided. The same way, if it's DCIS, so if the indication for the wide local excision was DCIS, there's a very different way of cutting it up because you need to map the DCIS to know the extent of DCIS. Now, that you need to know before. We would love to depend on surgeons entirely to tell us everything. Make sure that you know. Don't depend entirely on the clinician. If you've got the slightest doubt as to what the indication for the surgery was, either check the notes or even if necessary, make a phone call. Even if you have a delay, it doesn't matter. It's more important to get it right the first time. Okay, any comments on that one? If not, I'll move on. The next thing in our macroscopy, in our report, is a clinical history. So all of us in our pathology report, we include the clinical history, which is essentially an echo chamber, isn't it? We are just repeating to the clinician what he is telling us. So why do we put the clinical history in pathology reports when it's just reiterating information that is already known to the clinicians? The reason we do that is for 2 different reasons. First is medical legal. It's important to know what was the context in which the case was reported. What was the information that was available to the pathologist when he or she was reporting the case? So you are documenting that by putting it in the clinical history there. The second is it informs a clinician what information was available to the reporting pathologist. So suppose the clinical history does not say that there was a renal mass. There was a lymph node biopsy. and now if the patient they've done an MRI or a CT scan which revealed a renal mass, the clinician would want to call the pathologist and say, well, this patient's now got a renal mass. Could this be a metastatic renal cancer? Because on the other hand, if the request form, if the pathology report says clinical history, renal mass on MRI, the clinician knows that the pathologist was aware of that when reporting the slide. So the important bit over here is, in that clinical history, it is not enough to just put in what information was given to you on the request form. If you obtained any additional information, either from the electronic notes, the radiology reports, emails, phone calls, whatever, I think it is mandatory that you include that in the clinical history. So additional information from email or additional information by phone call, and you add that because you had that information when you were reporting that case, and that information should be part of the pathology report. Any comments? If not, I'll move on. So, okay.
Hang on, Brendan has his hand up. Yeah. Brendan?
Yes, so quite often I'll check radiology for our odontogenic lesions, for example, and I'll check it on the PACS system, and I'll put in the micro radiographs accessed on PACS, for example. And also for mucosal lesions, I'll look at the clinical photos that are available on the MIM system, and again, I'll say a clinical photograph was accessed in the micro section as well, just to add more meaning.
Neil?
Yeah, just comment on clinical data. Murali, I agree with you entirely. I think it's really essential to have it on there, particularly for review cases that are coming from other hospitals for your tumor boards or your MDTMs, whatever you call them. It's often the only information you have when you're reviewing the case before the meeting, so you have to have that full information. I have long experience of looking at a lot of reports from a lot of hospitals in the UK. We're only going to blame the UK, and a hell of a lot of garbage is written on request forms by our clinicians. We have an absolute rule that we get the endoscopy report every single time, because they don't lie on the endoscopy report. They lie on our request forms, our clinicians, but they don't rely, because that report's going to the GP, to the patient, and to other clinicians. The other thing I want to address generally in this whole symposium is who puts the information on the request form. And I'm afraid in too many departments in the UK, it's secretaries who do it. And you can clearly see that from just reading it. You know that they don't understand what's being said. And I also say that about the macroscopic descriptions. Often it's the clerical staff who do it. And okay, my secretary types it, but I say it. I dictate the clinical data. I dictate the macro. And I insist on doing that because I hate typos and I hate lots of other things on my reports, and I think we should all do that. And I think if particularly clerical staff are doing it, it's inevitably going to be inaccurate, and I think that's poor practice.
I think, Neil, I would agree with that. And I think the other thing I would also add into that, often the clinicians scroll on the request form, and we are trying to decipher what they have written. So, and you do get typos. And I also noticed that there is a tendency for pathologists to check the macro and micro more carefully than they do the clinical history. So you're often more typos get slipped through in the, now many of those typos are harmless, but some of those typos are significant. The last point I would make is in the clinical history, I wish the clinicians would avoid using acronyms. Acronyms are extremely dangerous because the same acronym can mean very different things. Like SCC can mean small cell carcinoma or squamous cell carcinoma, depending on who you talk to. You talk to two cardiologists, MI can mean myocardial infarction or mitral incompetence. So I think in medicine, we should try to avoid using acronyms. We might know exactly what we mean by it, but the reader might not. Jason?
Hi, yes, this might be the end of my career of GI reporting, but I disagree with the last point. I don't think it matters who types up the clinical details or the macro, as long as the consultant who authorizes report realize it's incumbent on them to check the clinical details and the macro carefully, and they take responsibility for it. Regarding acronyms, personally, if the request form comes with an acronym, I repeat it exactly as written. I don't try to interpret it. Our secretary interpreted it. I put it back to what was written on the request form. Like you say, I don't know exactly what that means.
Yeah, so I agree with you that if you have an acronym, don't try to expand it because you're more likely to create problems. But I think we should encourage people to avoid using acronyms. And the times when I've seen radiology and pathology reports with SCC on it, right? I know for most people, SCC is squamous cell carcinoma, but I've also seen SCC used for small cell carcinoma.
Can I just follow up on what Jason says? I sort of accept what you say, Jason. The trouble I have is that if a secretary or let's say a clerical staff is reading a request form and putting the information on and the macro as well, I just see from long experience that somehow the approving consultant doesn't take responsibility for that and doesn't look at it. And too many typos, too many errors, as Murali said. I think if senior staff take more responsibility for putting on the macro and the clinical data, then inevitably it'll be more accurate. And that's what I'm trying to get here. I don't care who does it, as long as it's accurate. But I do see over and over and over again that it is not accurate when let's just say the senior pathologist reporting the case is, let's say, not taking responsibility for it.
I would agree with you, Neil. I mean, they wouldn't dream of delegating the responsibility of a referral to a physician in cardiology, for instance, with inaccuracies and the minimal amount of information. So, yeah, I don't think our clinical colleagues take the pathology request form as seriously as they should. Murali?
Shall I move on then? Okay, so we've now sliced the specimen. So the next thing is to describe the specimen. So the first point I would make is sometimes pathologists go overboard with the description, right? So you got even like we do with microscopy, square cells, round cells, and whatever cells which nobody cares, right? The same thing with macroscopy. Try to keep it brief and clinically relevant. So here's and this I see this in the UK more and more commonly, and this is partly, I think, it's a problem with the Royal College data sets. So this is a partial nephrectomy report. Renal sinus invasion not assessed. Okay, fair enough. You might get a renal sinus in a partial nephrectomy, but IVC invasion, adrenal gland, lymph nodes, they have not submitted these specimens. So why do we have to put in our report that these were not assessed or not applicable or whatever? You only need. So I think we should. If we put too much information in there, then don't be surprised if the clinicians don't read it and they miss the more important bits. So a lot of this in a partial nephrectomy is not really necessary. So what is the risk of having redundant data? What's the harm? Play it safe, belt and braces, right? It's a waste of time. The report goes through multiple pages. It obscures relevant information and typos can be missed. So here's an example of a missed typo. Okay, this was a significant missed typo in a King James's Bible in 1631. This was, I think, one of the first Bibles published in English. It had a typo. And the eagle-eyed among you have probably spotted the typo because whatever the 10 Commandments said, it definitely did not say, thou shalt commit adultery. That was not one of the 10 Commandments. Okay, as you can see, there was a minor typo with the word not being missed. This had very serious implications because about 1,000 copies of this Bible, what has been called the Sinner's Bible, was published. King James was furious. He wanted every single Bible retrieved and burnt. Most of them were burnt. I think about 6 or 7 of them survived and then were sold in Christie for fancy amount of money. The printer, Robert Barker, died in a debtor's prison, all because of a typo, right? Now, with a histopathology report, the typo might not end up with you ending up in prison, but a typo can have very serious implications for the patient. I remember I do some sessions helping out in the cancer registry. And we came across a report which had been from several years earlier. It was an old report. where the microscopy said none of the lymph nodes show metastatic carcinoma. And the bottom line said 1 out of 10 positive, lymph nodes positive. So obviously there was 1 and none had got mixed up. There was no supplementary report. So clearly that had not been, we had no evidence that that typo had ever been corrected. And we had no idea whether the patient had been treated as 1 or none. So what I'm trying to tell you is that these typos can have very significant clinical implications. And finally, the specimen description. Remember, you got 2 different specimen descriptions. You got the one that is done at the cut-up bench and the one that is in the final report. They're different. They're for different reasons, different purposes, and need to be dealt with differently. The gross description at the cut-up bench is primarily an aid for microscopy. The gross description in the report is for the clinician. So what has been dictated at the cut-up bench is not a medical legal document. So it's not, you are allowed to change it. So when you're doing the micro, when you're issuing your final report, if you got something that looked like a tumor macroscopically and it turns out to be non-neoplastic, consider using word like mass. So replace that word with tumor with mass. If you got a discrepancy between the number of lymph nodes or the margin positivity, you are allowed to modify that macro so that it doesn't have to be that the macro has to be kept the way the person did it. And then finally, as was mentioned by Deepthi earlier, I think, is that photographs are very useful. So a picture is worth 1,000 words. So instead of a long description, often a photograph in salient cases is very, very useful. And these days, it's very easy. You don't need a fancy equipment. Just a mobile device like an iPad could be used. And this is a better record of no focal abnormality than random sections. So just taking 1 or 2 sections of the background and saying that there is no focal abnormality doesn't mean anything. But if you take slices and then lay all the slices down and take one photograph and say, see, here is clear evidence that there is no focal abnormality, that's a much better record of the absence of a focal abnormality. And I think now in the age of digital pathology, I think with macro, we should consider moving to using video macroscopy more. Now, this potentially has multiple advantages. It facilitates live second opinions. So if I've got a relatively inexperienced operator, they could ask for help from the consultant. Or if I am a uropathologist and I've got something in the gynae specimen, and maybe I can get help from a gynae pathologist. Or if I've got a problem where I need help from the surgeon, instead of the surgeon actually coming down to the pathology department, I may be able to do it online with video macroscopy. It allows retrospective review. So if we do video macroscopy, and if something has been missed, like the size of the tumor or the size of the specimen or size of something that's relevant, that could be retrospectively retrieved if you have a ruler with the video macroscopy. And then you could have screenshots. So if we do video macroscopy, we don't have to keep those videos for perpetuity. The videos, like the fresh specimen, like a specimen, needs to be kept only for a few weeks after the specimen has been reported. But the reporting pathologist has the option of taking screen grabs, that which can be then stored indefinitely. So you take screenshots from the videos, that could be put in a report if necessary, or it could be used for recording the absence of any focal lesion or whatever purposes. And finally, it would form a useful teaching tool. Now, whether this is feasible, I don't know, right? This is not standard practice anywhere, but it's something I think we should at least consider. And as I said, as a teaching tool, because this could be another way of providing feedback, supervision, guidance for less experienced operators. Any comments on descriptions and microscopy and the photographies? Yeah,
Paramita.
Yes, all excellent points, Dr. White. So we spend a lot of money to buy a grossing station with a camera, but we found it is so tedious to use. nobody would use it. And when we were sitting at reporting, it was not linked to the LIS, and we wouldn't be able to retrieve those images. So we started a policy where every fellow, they just put their mobile phone out and document every. We are a cancer hospital, so photographs are taken for every case. And the fellow themselves need it because, well, the specimen comes to you after day 5, sometimes takes 4 or 5 days in a center like ours to get all the 100 slides of a breast specimen. And like you rightly said, that on grossing, they look like tumor, but we have to back calculate, like the post-neoadjuvant breast specimens, breast tumors, we have to back calculate the tumor size. So we use a flap diagram, and we really need those photographs without which. So it's mandatorily followed for it. And it's so easy to use your cell phones now. And they delete it. I mean, it's difficult to store them for like 10 years. Leave it with the tag with the case number. Those we've tried that. It's difficult. For reporting, it's a very practical solution.
Yeah, I think the problem comes confidentiality. So, so generally we would be very reluctant to take photographs with our mobile phone for a reason. So what we have in our department in Cardiff is we have iPads, the departmental iPads at the cut-up bench, and the photographs are taken on the iPad and then electronically transferred to the database.
We tried all that. We bought a very expensive camera, but when it's one camera in the department, retrieving that and doing it real time, when you're sitting at microscopy late at night, it's very difficult.
Sure. Have you tried using something like a mobile device, like an iPad? Or, I mean, I'm not trying to, promote Apple, but any device of that sort, which is mobile, because the fixed cameras are very awkward to use, isn't it? While
so they're using
mobile ones are,
mobile ones, yes. But again, when it's one camera in the department, access is harder. Unless it can be linked to the cloud and everybody has access when you're reporting late at night.
I guess one suggestion I would have is, which you may want to consider, is buying a mobile phone for the department, which is linked them. That's a departmental one which is protected. So it's not, so then the confidentiality thing, it becomes a device which belongs to the department.
It's something like when we think our Facebook has privacy settings, nobody else can see. That's a myth. So once it's shared, actually anybody can use it. So we go by trust. And another good point you said, that the most typos are in the growth specimen. Our fellows will proofread the microscopy very, very carefully, but the gross part is often ignored, and they get all kinds of very, very wrong, discrepant areas from the microscopy. So that's another challenge.
Thanks.
Monica?
Yeah, thank you. Again, all great points. And specimen photography is actually like a pet peeve of mine. So I really, really love this topic. But one problem that we run into like every year with a new crop of trainees is, I feel like we do have good protocols for grossing and instructions for that, but not for no instruction on specimen photography, right? And what happens is we often have, when we go back to look at gross images, we find pictures of intact organs and then no pictures of slices. So those pictures, the intact pictures, are basically useless for me, right? And somebody actually spent time taking those pictures, but then didn't, and that happens because there's two different people handling specimens, right? When the specimen arrives, somebody's doing the inking and cutting and fixation, and then later when the specimen gets grossed, they forget to take pictures. So I think specimen photography should be a part of the training, and maybe more detailed instructions for trainees should be available. I don't know a good solution. Sorry, any thoughts are appreciated.
Good point. Deepti?
Yeah, all great points, Morley. Thank you. So first of all, I'm still curious to hear like what is the photography protocol from at different institutions. And the second thing, like you bring a good point about like redundant information in the report, but I think, sometimes we have templates, right? And when the PAs or residents are using templates, I mean, it's good and bad. Good because, they sort of cover everything, but bad in the sense that, sometimes you'll have redundant information which is not needed in there, and it would be a lot of like not applicable. Do we actually need it? So yeah, I mean templates, and even like similarly for microscopy as well. Like we do synoptic reporting and we put all these like synoptic reports. But then if it's a YPT0 tumor, like a neoadjuvant treated tumor with no tumor left, I mean, I'm filling up the synoptic reports and I'm putting no invasive carcinoma, no invasive. I mean, it's a lot of redundant information, but again, we do this synoptic, so we put it in. So I don't know what's the solution or what's the best
Two
practice.
solutions, I think, Deepti, what I would suggest. One is, yes, judgment, isn't it? So you make a final judgment as to what is important, what is not. Because some of this, what has happened is, if you have an electronic field, which is then that data is going to be electronically transferred to a database, then obviously you have to put everything in every field. But the final report that goes to the clinician doesn't necessarily have to have all these non-applicable ones, isn't it? And that's where I think, because the report simply goes into pages. So I think, yes, I think there is no single right answer, but
Yeah.
we should try and reduce the amount of redundant
Like for synoptic
information.
reporting, we cannot sign out the report till we fill all the columns in. So there
Yeah,
is
I think
like
that's again one of my pet bugbears. I would love to have the option of where you have the option of the synoptic report is great so that you don't miss out anything by mistake. I don't forget to put a data in, but it should give you the option of excluding that field item if it is not relevant in that case. Right? As pathologists, I think, as I said, some standardization is good, but sometimes I think we go over the top. Paramita?
Yeah, very briefly, somebody had mentioned about the block keys doing away with it and standardized grossing protocols, and we won't need. Standardized grossing also involves standardized surgeries, and we don't have that one. So when we get variable specimens for an LAR or for an oophorectomy post CRS specimen, so it's very difficult to not have block keys because your grossing will change.
Thanks. I think all these points are excellent. Okay, the points are all made, and I think this discussion is very, very useful. I think Ranjan just sent me a message that there are a lot of questions on the Q&A. So we need to take some of those questions, and maybe we will go a little bit more quickly so that we make sure that we do finish the session by 12 or at the most 12:15. Okay, so that we don't go too late. Adam, quick one, and then we'll move on.
Thanks, Murali. I just wanted to sort of comment where I use the macroscopy is essentially in head and neck, which is obviously quite a complex anatomical area. I actually use it more in the cancer multidisciplinary team meetings. That's both the sort of overview, but also the cut slices. My reason for that is the surgical and oncological teams have a better appreciation of that than necessarily the microscopy, which we've specialized in. And so for me, I use very little microscopy when it comes to our cancer meetings, and it's almost entirely macro based, essentially. So that's where I feel a priority for me for the macro is so not just exclusively from a pathology perspective, but just sort of communication with your surgical and clinical teams.
I would second that. I think surgeons are much more comfortable with the anatomy than the histology, right? And again, it depends on the specialty. There are some specimens where it is relevant. In other specimens, they couldn't care less, right? Ranjan, do you want to take a few questions from the Q&A first?
They're quite diverse at this stage, Murali.
Okay.
Do you want to finish your
I'll tell you what, Ranjan. Let me proceed with the presentation.
I think so. Finish,
and if you want to
we'll
collect some of the questions, then at the next break, we can take some of those
I think
questions.
so. Complete it because you may answer some of them, and then we can devote the rest of the time to the questions. Okay, go ahead.
Of course. Thanks. Okay, when it comes to specimen measurements, I think, again, this is something else that as pathologists, we go over the top. So when like a nephrectomy specimen, let's say regularly I see reports which includes the dimensions of the kidney with the tumor and the fat. Unless the patient wants to know how much fat reduction has occurred, what is the relevance of the perinephric fat, the size of the perinephric fat? It has no relevance. So we should try to avoid putting that. I've seen cystectomy reports where it's been inflated, and then you give the dimensions of the cystectomy. It has no relevance. So a lot of these dimensions that have no relevance, we don't need to put them in. So I think so. Sometimes I think we put in dimensions which simply adds numbers to check, creates work for everybody for very little value. And then you get this sort of thing. Like, so, here you can see that in the I think this data set is up for revision. I hope it does get changed, because it says the intact specimen may be weighed and measured in 3 dimensions, although these are simple. So again, this has no clinical significance. And personally, I would have loved it if the guidelines say, no, these should not be weighed and measured, because a nephrectomy specimen weight has no clinical relevance. So we should actively discourage the practice. Here's the data set from the endometrial cancer one. So here's about the weight of the uterus. It says many pathologists routinely weigh and measure all solid organs. And it says that the variability means that this has little clinical significance. And it says it's hence not included as a core data item. So it's included as the weight of the uterus and the measurements of the uterus are as non-core data items. The definition of a non-core data item means it's recommended but not mandatory. If it has no clinical significance, then why are we recommending it? Again, it's a 2017 document which is under review, and I hope this again changes in the updated version. Now, the uterine weight, it depends where you are. It may be absolutely critical, as the pathologists who are tuning in from the US will know that if you don't report the weight of the uterus, you will get a call from the surgeon. And that's because the weight of the uterus determines the surgeon's reimbursement. They have got the CP. So it's used as a surrogate for the complexity of the surgery. So if you're an American pathologist, it's critical that you report the weight of the uterus. But if you're a British pathologist, don't waste your time with the weight of the uterus. It has no relevance. Same way, the size of the specimen. Don't forget, both of these specimens would have exactly 3 by 3 centimeters. It doesn't tell you much about that. So be aware of that. So all these sizes, what you're trying to do is to give the idea, is it a small tumor? It's not about precision. So often when it comes to specimen measurements, it's perfectly okay to round it to the nearest 5 millimeters. In most cases, I'm not saying I'm sure there are exceptions. Maybe like if you get a lymph node dissection, you got fat and lymph node dissection, often it's measured in 3 dimensions. Now, depending on how I squeeze that fat, I can make that measurements into anything. So the size is not really reproducible. Actually, the weight of the specimen may be more reproducible. It's easier because it is a single figure as opposed to 3 dimensions. It's more objective because you're weighing it, and it's a surrogate for volume. Now, this is again one of the papers. I think this was one that did benefit to my CV to prove something that's pretty obvious. Most of our body, the tissues are largely water. So the specific gravity of tissue is approximately 1. So the weight in grams equals the volume in cc, approximately. Good enough, and that degree of approximation is adequate. So if you want to tell them, if you want an idea approximately how much of the fatty tissue was removed in a lymph node dissection or a wide local excision, then actually the weight of the specimen is more reproducible than the dimension. And again, when you give the weight, so here are the TURP chippings. It says weight 15.02 grams. You don't need that degree of accuracy. 15 grams is more than enough. Depending on the amount of formalin that you have got left on those fragments, the weight will change. Documentation of what was received, whether the hysterectomy was a total or a subtotal, or whether it was the fact that there was no focal lesion, that is more important than specimen measurements in most cases. When it comes to tumor measurements, in most cases, again, I'm sure there are exceptions, but in most cases, the only dimension that the clinicians can use in their guidelines is the largest tumor dimension. So the second and third tumor dimensions really has no clinical utility. And if you know where the clinically relevant cutoffs are, like if it's a renal cell carcinoma, 4 centimeters, 7 centimeter, 10 centimeter, you may want to be more correct near that area. Otherwise, you don't have to be wonderfully precise away. But even there, a 69 millimeter tumor and a 71 millimeter tumor the outcome is not really going to be very different, even though one may be PT1 and the other may be PT2. But I think so. These are kind of academic, maybe pedantic points. The one I think that is much more clinically relevant is tumor size when it comes to cystic tumors. So when you've got a cystic tumor, the size of the tumor depends on the amount of fluid that's in the tumor, and that may not be prognostic. And this can be clinically very, very problematic. So let's consider cystic papillary thyroid carcinoma. So you've got TNM8, a tumor more than 4 centimeter would be T3. So what do the NCCN guidelines say? That if a primary tumor is more than 4 centimeter, you give radioiodine. So more than 4 centimeter PT3, the recommendation then would be completion thyroidectomy followed by radioiodine. And that means this patient is going to have a lifetime of hormonal replacement. Is that really necessary for a purely cystic 5 centimeter tumor? Because that cystic 5 centimeter tumor, so if I don't have much solid components and most of it is just fluid, I think you, at the very least you can do, okay, that is the way we measure it. You measure it, but I think the pathologist should put a statement in there that the size of the tumor may not be representative of the tumor outcome or whatever. You need to flag it up for the surgeon that this patient is not like a 5 centimeter cystic tumor is not equivalent to a 5 centimeter solid tumor. And that is, I think, up to us to communicate that. I'll pause here. I think Neil's probably gone out. He's back again. Over to you, Neil.
Okay, just the 3 comments, and this is going to demonstrate what a complete pedant I am. And you said at the beginning, Murali, that you quite like some debate and disagreement. I'm going to first of all indicate some of your measurements were in centimeters there. I think all measurements should be in millimeters. And I think the Royal College says that standardly in the UK. I don't know about other countries. Now, this is where I'm a real pedant, is I have an absolute rule where none of my measurements in millimeters end in a 0, and pretty much none of them end in a 5 either. I think there is an important point, is I want my reports to look accurate to the clinician reading them. And if I have a little, let's say a little lump and it says 20 by 10 by 10, I would suggest to you that doesn't look accurate. It looks as though somebody has vaguely waved a ruler somewhere near the specimen. So this is terminal digit preference, where I, even in the days when I used to do autopsies, the poor morticians in Gloucestershire, wait for this, knew that if they said 1,500 for the liver, they were in big trouble. So it was 1,498. I want my reports to look accurate. They may not be accurate, but I think our clinicians want our reports to look accurate. And I don't think we should use terminal digit preference. So that's probably a controversial thing. I think no 0s, and I'm wary about 5s on the end. And the other thing I want to say is we're going back to gallbladders again. So the gallbladder is a cylinder. Please, no 3 dimensions, just 2. And the reason there are 3 dimensions, because you know, we all know that the length is fine. It's the width, is because it's been flattened, sitting in a pot of formalin. It's a cylinder. It's got a length and 1 width, not 2. And I think that's important and reflects that you understand anatomy. End of pedantry.
Yeah, it's fair enough. We're all different. Okay, so I tend to be on the other, like I probably go far too much on the pragmatic end. So I would want to be extremely pragmatic and extremely practical and put in only things that are of clinical utility. Now, as I said, there is no right and wrong. We are all different. Paramita?
Yeah, I'm feeling a bit nervous to disagree with Dr. Shepard here, because we do measure with the scale and we do want to be accurate. But again, a real world picture is our fellows do the grossing, and depending on how tightly the fellows are holding on to those slices, I have seen the breast tumor size vary in centimeters, not millimeters, like changing from 3.5 centimeter to more than 4 centimeter, grossly affecting stage. And again, 2 very good points you mentioned, Dr. Verma. I want to say that some of the evidence that we follow blindly is eminence-based evidence, eminence-based practice, so not so much evidence-based practice. I'll give you an example of grossing of Whipple specimen. Why do we don't get Whipples that frequently? And for us to do the bivalving method, which is followed in the US, is very, very challenging when in the Indian scenario. Does it make a difference? Most of our cases are periampullary. Why do we follow a very difficult grossing practice when you can just cut through the bile duct and probably get the same results? And your clinician doesn't care anyway because the patient is far beyond making any difference from our pathology detailed report in a periampullary or a pancreatic adenocarcinoma case. And again, like regarding lymph node count, we all like to have our count more than 12 nodes. Is there a perfect definition of what a lymph node is? I've seen some of my colleagues push any lymphoid follicle as a lymph node so that just the count, so that the count is 12. So who's reviewing, who's ensuring accuracy of all? So there's a lot of gap between what we think of our standards and what is actually happening in the real scenario.
Nice, Bhumika. Thank you. Jason?
Oh, yes, I'm going to disagree with Professor Shepherd again. I think there's a difference between rounding numbers and the terminal digit bias, which you introduce, as we see people commit research fraud, as well, detecting that. I think rounding is perfectly reasonable if the rounding doesn't change the clinical impact of the figure you're measuring. And I think that giving too many digits gives a false degree of accuracy. It may be precise, but not necessarily accurate. Having said that, I would argue that you have to be aware at cutoff of the clinically relevant cutoffs. For example, going back to Murali's renal cell carcinomas, I'd be very wary about rounding a 39 millimeter tumor or a 41 millimeter tumor. If you round it both to 40 millimeters, it's not clear exactly what stage that is. In some situations, so anyway, I'm being a bit hypocritical. In some situations, I do round. Other situations, I don't round when I think it is a clinically critical.
That's right, Jason. If I could add just one more point on that. Also, we got to be aware that we can measure 2 dimensions quite reliably, but the 3rd dimension is a guess. Okay, we are reconstructing, unlike radiology, where the computer does the 3rd dimensional reconstruction. We are trying to reconstruct by putting the slices together and trying to measure that 3rd dimension. It's almost always a guess. So this idea that there is a degree of imprecision in what we do, and that's part of it. Okay, let's move on. So we've now sliced it. We're talking about identifying the lesions. That's the next important step. So what we do is we look for areas that are different from the background. Lesions that permeate normal structures are more difficult to pick up. Thin slicing is a must. So if you don't slice thin, if you take 1 centimeter thick slices, a lot of sins can be hidden away in that. So you can miss a lot of lesions in that. So it's, again, I come back to proper fixation and thin slicing. The block key, keep it brief and relevant. The detailed block key may be critical for the reporting or reviewing pathologist, less significant for the treating pathologist. As I said, it may be reasonable to exclude it from the clinical report and have it only in the laboratory information system, so that you can include it in the report that is sent to the reviewing pathologist, but not as part of the report that is sent to the clinical treating clinician. Okay, I'm going to move on a little bit quickly. Okay, we'll come back to this because I'm a bit aware that time might be a problem. So we have identified the lesion. We've now got to sample the lesion. Now, sampling is absolutely critical. As I said right at the beginning, it doesn't matter who is doing the microscopy. You can't identify what has not been sampled. And then there's a question of how many sections of the tumor that you get. Now, this is one that creates a lot of argument. So here I've got a renal cell carcinoma. Now, I know for those of you who are GU pathologists, it'll be more obvious. For the non-GU pathologists, you can see this area here in the middle with a very variegated appearance. It's very yellow. That's because there's a lot of fat. And that suggests that it's a conventional renal cell carcinoma and probably a relatively lower grade conventional renal cell carcinoma. Now, if I take 50 blocks from that area, from this variegated area, I could end up reporting it as a low-risk renal cell carcinoma. But if you are a reasonably experienced GU pathologist, what you will recognize is on the side that you've got these white areas, these fleshy white areas, that is maybe sarcomatoid change. That was sarcomatoid change. So my point I'm making here is it's not about how many blocks you take, but where you take the blocks from. You could take 100 blocks of that variegated area and still get the wrong diagnosis if you missed the. So it's more important to take thin slices, carefully examine the specimen, identify any area that looks different, and to sample it. So from where is more important than how many. I'm going to move on to this bit and we'll talk about sampling together. So the next question then is, how many sections should we take? And all our guidelines have, 1 block per centimeter maximum dimension, or in some cases, 2 blocks per centimeter maximum dimension. I would like to seriously question this. Is this rational? Is it entirely ambiguous? So what is a block? So like in a total thyroidectomy specimen for Graves' disease, the Royal College guidelines here would say 2 blocks from each lobe. The Royal College of from Australian pathologists would say 3 blocks from each lobe. So what is a block? Are we talking about a paraffin block or a tissue block? And those two are entirely different. If I take these 2 pieces, and put them in 2 cassettes, they're clearly 2 paraffin blocks. But if I take those same 2 slices and put them in a single cassette, is that 1 block or 2 blocks? So that is 2 tissue blocks in 1 paraffin block. So what are we talking about when we say X number of blocks per centimeter maximum dimension? Because a block is not a measure of tumor amount. It's entirely arbitrary. So if you really want to talk about the amount of tumor that has been submitted, then we need to talk about so many square centimeters per centimeter maximum diameter. Then at least that is unambiguous. Now, again, what people come back to me quite reasonably and say, Murli, we've got a life. Okay, you are asking me to measure how many square centimeters macroscopically? Of course I'm not. I'm asking you to eyeball, like you would do for percentage necrosis or percentage Gleason pattern 4. You just eyeball it. If you almost fill up the cassette, almost fill up, okay, not fill it up, where you leave enough space for formalin to go through, that's about 5 square centimeters. Half of that is about 2.5 square centimeters or 2 square centimeters. So you eyeball it and you have an idea about how many square centimeters. So if our guidelines want to talk about now the amount of tissue that is submitted, I think we should talk about so many square centimeters of tissue. Talking about number of blocks of tissue is meaningless, because I could put very tiny bits of tissue into a block and that would be a block, or I could fill up the block with tissue and that would also be 1 block. And finally, this whole idea of number of blocks is anyway far too simplistic. Each block samples only a tiny, tiny part of the tumor. This is what I like to joke. What do histopathologists and ancient Egyptians have in common? I'll give you a few seconds to have a think. I'm sure you can think of many exciting things. But the one that I would say what we and ancient Egyptians have in common is we are both into embalming tissues never to be seen again. So if I all embed a specimen and put it all into blocks, I put it all into paraffin, I only take 1 5 micron section from each of these blocks. The rest of it is going to remain in paraffin for eternity, or 30 years, or whatever the time limit is before those paraffin blocks are put away. So as pathologists, sometimes we seem to get this great satisfaction by transferring the tissue from the formalin pot into the paraffin cassette. And we consider that we've done a much better job because we've transferred everything into a paraffin cassette, even though we have only examined 1 5 micron section. So 1 5 micron section examined from each 3 to 4 millimeter of tissue would amount to 0.15%. So if I take a mastectomy specimen and all embedded in God knows how many ever blocks I'm going to put, I still would have examined only 0.15% of that specimen. When I all embed a radical prostatectomy, I have only examined 0.15%, or it's actually even less than that, of the margins or of the specimen. So be aware of that. However we do, how many ever sections we take, we are only examining a tiny bit, which is why macroscopy is so critical. Because with macroscopy, we are visually examining the entire surface, and then we are sampling the areas. But just by putting the tissue into paraffin, it sounds as if we have all embedded it, completely examined it. I think we are only fooling ourselves if we think so. The sampling macroscopically different areas is more important than the number of blocks. And if you've got a homogeneous tumor, like an obvious fibroid, which is very homogeneous, which every area looks identical, do we really need as many blocks? We probably need fewer blocks from a homogeneous tumor. While a heterogeneous tumor, you've got to make sure that you sample every different area. In a homogeneous tumor, whether you find an area with mitosis or whatever is a random phenomenon, whether you're going to find. So I don't think taking a lot of blocks from a homogeneous tumor can really risk stratify individual patients. And when you say so many blocks per centimeter for a cystic lesion, the size of cystic lesion, like an ovarian tumor, it depends on the amount of fluid. And there's no evidence that a cystic ovarian tumor has a higher risk of malignancy than a solid ovarian tumor. If anything, it's the other way around. We should also, it's important that we tailor the sampling to the setting. An ovarian tumor with obvious omental metastasis does not require extensive sampling. Now, if it turns out on histology that those turn out to be implants, yeah, you can go back and take more sections. But if you've got obvious mets or lymph node mets, you don't need to take a lot of sections from the ovarian tumor to find that microinvasion. A renal cell carcinoma with renal vein or IVC involvement does not require total submission of the renal sinus because this patient's obviously got worse, higher stage disease already. When it comes to diagnosis, as pathologists, we are very much into immunohistochemistry. I would make a plea for extra blocks. So very often, more than taking immunohistochemistry is additional blocks might have a better differentiated area where both the diagnosis might become more obvious on the morphology and the immuno also may be more reliable. If you get a specimen that is submitted in multiple pieces, it is not necessary to submit an aorta. A segment of aorta submitted in multiple pieces, there is no requirement to submit each piece separately. It's a one single piece. Same way a breast reduction specimen. Just because the surgeon has submitted it in multiple pieces, you don't have to process it in separate pieces. Okay, can we take any comments, questions, suggestions, other approaches?
I think let's go on, Murali.
Yeah, okay, Ranjan, I think we'll move on. Finally, I would like you to get you to think differently. So as pathologists, when we think of specimens, we think of small specimens, large specimens, biopsy specimens, resection specimens. I suggest that we should consider specimens in a totally different way in a clinical context. So I would say, think of specimens as diagnostic specimens, prognostic specimens, and therapeutic specimens. So if I take a thyroid specimen, a thyroid needle biopsy is a diagnostic specimen. So it's primarily done for the diagnosis of that lesion. A lobectomy is for prognosis. So often, I'm not saying it's not for diagnosis, it can be for diagnosis and prognosis. But here you need, so in a needle biopsy of the thyroid, the size of the tumor is not relevant. In a lobectomy, the size of the tumor is relevant. But when you get a completion thyroidectomy, so you get a patient who's got a follicular carcinoma and they've removed the other half of the thyroid gland. Now that is a therapeutic specimen. Now, why have they done that completion thyroidectomy? And what is the clinician looking for from that? He's looking for nothing. He has done the completion thyroidectomy to facilitate follow-up and radioiodine therapy. Because if they give radioiodine, if the other half of the thyroid is there, it's going to take up all the radioiodine. So they are removing the other thyroid lobe only so that they can give radioiodine to the patient. So this has very limited clinical utility. So yes, examine it macroscopically, and if you find a tumor there, macroscopically, it makes sense. But submitting 2 or 3 blocks from a completion thyroidectomy, which is essentially a therapeutic specimen, is of very little clinical utility. And again, there are several therapeutic specimens. We can talk about completion thyroidectomies, thyroidectomy for Graves' disease, TURPs for BPH, prolapsed uterus, tubectomies, vasectomies, breast reduction specimens, could go on forever. These specimens have been done as part of a treatment process. It is reasonable for us to fix them properly, take thin slices, do a careful macroscopic examination, but after that, taking a lot of specimens, random blocks of no focal abnormality, I don't think personally that's particularly good use of pathology resources. An example of that is a thyroidectomy for Graves' disease. How many blocks should you take? The RCPath guidelines in the UK says 5 blocks, 2 blocks from each lobe, 1 from the isthmus. The Australian guideline says 7 blocks, 3 from each lobe and 1 from the isthmus. And this is for with thyroidectomies with no focal lesion. What for? It's a therapeutic specimen. The diagnosis of Graves' disease is based on clinical and serological features. So the surgeon is not looking for the pathologist to make a diagnosis of Graves' disease. He's already made the diagnosis of Graves' disease. These patients have generally been treated medically for Graves' disease. The medical therapy has failed, which is why they've done the surgery. So they are not looking for us to confirm the diagnosis of Graves' disease. And either way, very often you won't be able to, because these patients have been medically treated. They very rarely will show the typical histologic features of Graves' disease. So what are we taking all these blocks for from a thyroidectomy with no focal lesions? And this is a paper that is, again, a bit tongue-in-cheek, that we had written in the archives of pathology and lab medicine, essentially charging pathologists with, well, I wouldn't say misconduct, that might be too strong, but saying that essentially we are causing cancer overdiagnosis. Because by doing these, by taking a lot of sections from TURPs and thyroidectomies, we find incidental microcarcinomas. So either Gleason 3+3 carcinomas or papillary microcarcinomas. And then this patient is saddled with all the impact, the psychological, financial impacts of a cancer diagnosis. Extensive sampling of specimens with no clinical suspicion of malignancy, I think it amounts to screening. And if that is so, we don't have a consent. The patient has consented for histological examination of the specimen. He or she has not consented to histological screening of the specimen to find any incidental prostate cancer or thyroid cancer or any other cancer. So systematically sampling specimens to find incidental cancer, personally, I don't think that's warranted. Ranjan, I've got a few slides left. Should I finish and then take the questions?
Yeah, I think so.
I think that's finished. I think we're almost finished. So surgical margins, critical for assessing the completeness of excision. It's an audit of surgical performance. But I would like to explain that when we and the surgeons talk about margins, we are not talking about the same thing. When I talk about margins, I'm talking about the specimen margin. The margin that the surgeon is interested in is the resection margin. And the resection margin and the specimen margin is not necessarily the same. And that's because specimens may be disrupted either during surgery or in the laboratory. So if that's a breast tumor, so I've got the tumor and I've got the fat, then that is the resection margin. And that is the distance from the resection margin. But during surgery, if the surgeon makes a nick on that resection margin, the tissue will retract. And when the tissue retracts, when I get it in the lab, that's what I see. That was the resection margin, but that is what I see as a specimen margin. And what I would measure would be that. So the distance that I give is not the distance from the true resection margin. It is the distance from the specimen margin. So personally, in my reports, I always specify specimen margin as opposed to just say margin or to say resection margin. Here's another example in our prostatectomy. Quite often you see that surgeon has gone to the wrong plane and then corrected it. So you get these bits of tissue which are hanging in the air. They're not hanging in the air. They are obviously connected to the specimen in a different plane of section. So if I've got something like this, I've got ink there. but that is not the resection specimen. That is not the resection margin. The resection margin is up here. And so that if this flap, if the section was taken in a different plane, the flap could fall off and all I would have there. And if I had a tumor over there, I would call it positive at the margin. Now that's actually a false positive margin because that's not a true resection margin. That is a true, that was a specimen margin. So be aware of that the specimen margin and the resection margin may not be the same. And this will be true in some specimens more than others. In some specimens, it's a very clean cut and the resection and specimen margins will be largely the same. Other specimens, there'll be more disruption and they may not be the same. So it is important to be aware of that. Tumor at the ink doesn't mean that it's at the margin because ink often leaches into the tissue and the surface with the ink may not represent the margin, like in the radical prostatectomy that I showed you, where there was ink over there, but that was not the true resection margin. Here is a breast specimen. You can see that quite clearly you will get ink leaching down through the gaps in the fat. And so that can often be a problem when you're assessing margins. So what it really means is the other way around. So if you have inked the margin and in your section, the tumor is at the edge of the section, but is not in contact with ink, there's no ink over there, that would suggest that that section was probably not properly cut and you may want to take deeper levels that may not be margin positive. But just because tumor is at the ink doesn't automatically mean that it's margin positive. Margin assessment is more reliable for expansile lesions as compared to infiltrative lesions. I'm going to leave these few slides because I just want to make a few important points that the macro might overestimate distance from the margin, especially for infiltrative lesions like globular carcinoma, which you cannot see properly macroscopically. So what appears to be far away from the margin, it may actually be closer. While in other cases, the macro might underestimate distance from the margin, as for example, when you got a lot of peritumoral fibrosis. So the fibrosis is very close to the margin or at the margin, it may not be tumor at the margin. And again, you got the question of whether you do a shave margin or a cone margin. The shave, the advantage is it examines the whole of the margin, but the true margin is lost when facing the block. And you cannot determine the distance from the margin. So like in the colorectal, etc., if you got a certain distance from the margin that you would consider as margin negative, you cannot do that if you're doing shave margins. Cone margin allows this measurement of the distance from the margin, but it would sample only 0.15% of the margin, even if you submit the whole of the margin in a cone fashion. Right, I think we will stop over there, Ranjan, and I think let's take all the questions. So I'm going to stop sharing here. Ranjan, we've got about 10 minutes. It's okay for us to go about 10 minutes over time should be okay, because we've got an hour between this and the next webinar. So I think Ranjan, what I suggest is let's get the panelists in first.
Sure.
And then we can take the questions.
Okay, well, I'd like to thank you very much for that tour de force, really, thought-provoking, wide-reaching, lots of food for thought. Neil, do you want to comment? You've got your hand up.
Yeah, Murali, that last, your whole presentation was brilliant. That last bit of the presentation was exceptionally brilliant because you talked about distance to margin and involvement of the margin all the time. I have a very, very strong view that we should never on our reports have the words incompletely excised. I think that is so bloody rude to the surgeon or the dermatologist or whoever. It's a widespread practice in the UK. We should never, ever use those words. We should say it reaches the margin or does not reach the margin. So I'm involved in 2 national guidelines and we've removed any reference to incomplete excision. So years ago, we had a locum here, a dermatopathologist, who used to report on shaves of intradermal nevi, and the report would read intradermal nevus incompletely excised. Now, dermatologists shave nevi and they're no interest in margins at all. If a few nevus cells are left behind, it doesn't matter. We should not use those words. And I've been trying for years to get our Royal College in the UK for all the data sets not to have the words complete excision, and I think complete excision is wrong. It's not rude, but I think it's wrong. And the reasons you gave for the prostatic surgery are apposite here. You know, we cannot say it's incompletely excised, but much more importantly, let's make ourselves more popular with our clinicians. I don't know how many of you read my thing, but I did say that when the BMA did a review of the popularity of specialties with other doctors in the UK, this is, pathologists came second last. They were the second most unpopular people. And I would suggest it's because of some of the words we use. Now, you're all wanting to know which specialty was bottom, aren't you? I can see Ranjan does that there. Well, I'm not going to tell you. Psychiatrists. Yeah, I feel so strongly about this that I'd be interested in other people's views. Incompletely excised. How bloody rude is that? It suggests the surgeon's done a bad job, doesn't it? Straight away.
I use tumors present at the inked margin.
Yeah, and so does Morley, but there's a huge cohort out there, Ranjan, who don't. Enough said.
I think, Ranjan, the only bit I think I suppose I would add the word specimen. So I would say at the specimen margin.
Yeah, sure. At the inked margin of the specimen.
I would say at the inked specimen margin.
Correct.
Because I can never be sure whether that is the true resection margin.
Sure. No, I think margin, obviously, of the specimen. Paramita?
Yeah, so I do a lot of different subsites reporting, and how we look at margins is very variable depending on the site. Say, for example, for breast, our surgeons use a cautery knife, and sometimes the cautery knife comes in. So if you just look at cautery or just look at ink, it's not enough. You have to look at the outermost surface and exclude where the knife has gone in, but that's not really the surgical margin. For head and neck, for example, when you're looking at a larynx specimen, the lateral surface is actually a surface. It's an anatomical, there's a fascia, but it's not very clearly defined in the guidelines. So if you're going to report that as lateral margin positive, there is nothing beyond that that the surgeon can take out from the patient's body. So maybe frame it accordingly, like not just margin positive, but the tumor reaches the surface, lateral surface. So these variabilities are important to understand what it implies for that patient, for that specimen, and the management.
Sure. Dipti? You're on mute, Dipti. Oops.
Sorry about that. Just a quick comment, and we can discuss this more during GI thing. I could not resist to say that do not confuse serosal surface with margin. Because I have seen that happen multiple times in extramural consults. It's a serosal surface. It would be called as a positive margin. No. It's different.
I agree, Dipti, but don't paint it. I don't know if you picked up that controversy between your article and mine in the J. Clin Pathol, is I would say never paint a serosal surface, only paint a margin for that very reason that you give. When you're in your tumor board and another pathologist is reviewing it and they see paint on somewhere, they'll think it's the margin. If you
can still figure out it's the surface and not the margin, but yeah, I guess, no?
I have other reasons why you shouldn't paint a serosal surface.
If you have your T2 sections, you would know. If you have your tissue block. I like painting the serosa because when the PAs cut the sections, we know that they've not had an incomplete cut and they've actually gone to the end of the serosa. If I can see the ink. So one of the common problems we have is they cut.
You see the
microtomy.
serosal surface. You see the peritoneum.
Cells.
Yeah. Another controversial area, clearly, where we won't agree.
Okay, shall we take some?
We probably should take some questions.
Take some questions, exactly. Okay, so what I'm going to do is I'm going to start with the latest ones first, and of course we've got quite a few questions. There's one perhaps directed to you here, Murali. Would it be good to mention the details with respect to margin measurement? Should a specimen have double inked margins like in the prostate?
Sorry. Can you repeat that, Ranjan?
Would it be good to mention the details with respect to margin measurement? Should a specimen have double linked margins like in the prostate you demonstrated, I guess? I.e., say that, you've got a flap, etc. I think that's what
I think, yeah.
Eamon
So
is saying.
when you have a flap, for us in the prostate, we just report margins positive or negative. So we don't give distance from the margin. Okay. So, but the key thing here is, I was trying to demonstrate that to say that I have other cases. I think like in the publication, I think in one of the papers, I can't remember, probably in the GU paper, there's a case where you had a flap like that, and there was actually tumor there at that inked area on what would have been the surface if the flap wasn't present.
Okay.
So it is just to be aware of that. So I wouldn't give separate distances. If you had that sort of case, you make a judgment call.
Sure.
And take the distance from the outer one, because that is what you think is the true specimen margin. I think all of this, at the end, I think the discussion is pretty obvious that this is a very imprecise thing. The margin assessment is not perfect. It's an extremely imperfect stuff, and you're using your judgment to give what you think is the best distance.
Okay, with reference to extensive sampling, how would a minimalist model be created, or is it at a pathologist's discretion as to the minimum number of blocks taken? Or
I think with all of this, I think there are two things here. I think one is the guidelines, isn't it? So I would, if you're a practicing pathologist, you have to follow the rules. You have no choice, right? Because otherwise you could get into problems. But be aware of two things here. One, as I said, you got this ambiguity as to what is a block. I don't know what is a block.
Sure.
I don't think anybody knows what is a block.
Well, related to that, Jamie Wilson's asked, can't the RC path assist in defining what a block is? I mean, a block is a block,
yes.
as far as I'm
that's
concerned, irrespective of the amount of tissue in it. Paramita?
Yeah, so we have, correct. So that's basically, we are trying to get that debate going.
Yeah.
Right. So this is a start with that.
I think Monica
Paramita.
mentioned this, that the junior people doing the grossing tend to give more blocks. So one standard dictum I tell my trainees is that when you're giving more than 6 sections from tumor, you have to explain to me the reason for each section, or I'll charge you. So that's one way of getting more cost efficient.
Sure.
We have limited.
I suppose the question I would ask obviously is, are those 6 sections in one cassette or in 6 cassettes?
That's another story.
So this is the point. So a lot of this
That's margins and all are
kind of,
separate. This is just 6 tumor blocks, because they tend to give like 10, 15 tumor blocks. We get large tumors in our country, and the n number of breast tumor sections, which we don't have the time to see. So it's just we don't have the time to store them. The storage is also expensive. So, and like you rightly said, for prostate, for cystectomy, giving the entire prostate in an 80-year-old getting a radical cystectomy, what's the purpose? Why would you put the entire?
Okay.
Well, Paramita, you give me a chance to boost my tomorrow's lecture then, because tomorrow in the GU section, I will be talking a lot about prostate, about sampling QRPs and sampling radical prostatectomies, and whether what we are doing makes any sense at all, and whether we need to change.
Okay.
So that's for tomorrow, the 6th session of this webinar.
What about using imaging measurements as opposed to specimen measurements? Thoughts on that?
So the only thing I would say is no. The imaging measurement is available to the clinicians. So that is for the clinicians to use it. So we give a measurement, but the final measurement ideally should be a clinico-pathological, clinico-radiological, pathological, whatever. Overall, what should be considered. But the only thing I would say, like for example, a renal tumor, it's not I would recommend generally to get your clinician to tell you what the radiological size of the tumor is, or to look up the radiological size, because that larger size may be in that 3rd dimension. So if you got a tumor that is shaped like this, and you take a cross section and you give the short dimension, which may be 3 centimeters, when actually it might be 7 centimeters or 4. So especially the ones that are close to the cutoff, it's not a bad idea to check the radiology report when you're doing the cutoff.
And regarding measurements, I think where stage is involved, I think the most accurate measurement is the one that's preferred. I think everyone would agree on that. Because if you're going to upstage based on your measurement, clearly you need to measure accurately and not round up. Is there a standard recommendation for embedding uninvolved lymph nodes completely or partially? I've come across pathologists who embed only half of an uninvolved node. Same for bisecting nodes at 4 millimeters or more in size.
Again, you see, I'll make 2 points over here. The first thing is, if you bisect a node and dump it in, you're examining the same surface. Yes, you're cutting away from that surface, but it's essentially the same surface that you are examining. So there's very little difference between that. And finally, even as I said before, even if you all embed that lymph node, you have still examined only 0.15%, 15 micron section for every 3 millimeter or whatever, right? So there is a sampling thing with all of this. Yeah, I'll let Neil take this further.
Go on, Neil.
Yeah, no, I'll just talk about a lymph node harvest again. So, can I just show you this is what we do in Gloucestershire. This is, whoops, where's my camera? This here, the 6 of dominoes. So we embed 6 lymph nodes in each blood. This is going back to block economy that Murali was talking about. I don't know how well you can see that. And actually, you can look at that picture here as well, and I might talk about that if we ever had time. So doing it like the 6 of dominoes. So people argue, well, how do you get big lymph nodes? In an audit we did, 98% of all lymph nodes fitted quite happily with their 5 brethren in one block. And this is all about block economy, which we should all be. We've talked about how people over sample things, but if you put them in like a 6 of dominoes, it means microscopic assessment is that much, because you go like that and you assess those 6 so much quicker than Murali, forgive me for saying it, but you used the word dump just then to put something in a cassette. I don't dump. I very carefully put.
I'm sure
and I
you
think
do.
that's a really important aspect of it. But that makes it much easier and a huge amount of block economy. And I commend it to you all. Instead of just random bits of fat, which we all see, don't we, Ranjan, far too often just dumped in a cassette in the hope that it might have a lymph node or 2. If you do it like that, and as I say, the vast majority of it, and just to answer the question about how much of it, those lymph nodes, it's about 2/3 of it goes in, but you're still only cutting one section. So it's the 0.15% that you say, Murali, but I commend that to you. You have to put a bit of foam in the cassette to make sure they're held in the right place. But then it makes the microscopic assessment so much easier and so much quicker.
Yeah, I think it's essential. I think whatever ways we can make to make things easier both for ourselves in the lab, because currently I think it's a global phenomenon, as Monica and Deepti said in the US. It's not just a case of money, it's staff. Getting experience, because the problem in pathology, unlike biochemistry, etc., it's very labor intensive, and it's very skilled labor. And I think we need to use our skilled labor very carefully. And when I say skilled labor, I'm talking about all of us, including me. So what I do is a highly skilled job, and I think I should be using my time to best. Same way, the laboratory staff are extremely highly skilled staff, and we should not be wasting those resources.
Just a related question. In head and neck resections, where lymph nodes are obviously involved with metastatic tumor, should we still embed them all?
I would agree. Any lymph node that's obviously involved, I'll just measure it and take one section to confirm that it's tumor. Now, again, there may be different rules in different specialties. Yeah, go ahead. Sorry, Parmita.
So I was going to comment on that. So first, to answer Dr. Chetty's question, so because extracapsular extension, the management changes, radiation guidelines are different, whether EC is present or absent. We are made to go back and put the entire node in if we don't find ECL. So yes, even with grossly positive nodes, we have to put it in entirely. When I started practice here 12 years back, standard practice in India was to submit one half of the node. And we had done an audit at that point of 100 head and neck cancers, where even though they are flaps of each other, this bisected node, one half was involved and one half wasn't. So we never published that. So now I can't recall what that percentage was. It was low, but it wasn't 0. So, I mean, we follow putting the entire lymph node in. And it's something, it's a good, I know some of it is redundant, but for case sites where it is critically important, the lymph node stage depends, besides the adjuvant treatment, like head and neck cancer, I think it's very important that we measure the entire weight. And
Sure.
it's good to have one standard practice.
Okay, Murali?
I think I'll make 2 points here. I think, when you talked about putting that those two pieces, one might not. There's no doubt if you go back and take deeper levels through those blocks, you will find extra, the ones we didn't have extra capsular invasion, you will find extra capsular invasion in the deeper levels. And then it's a question of how many levels you take. You obviously can't cut through all the lymph nodes through the whole sections. So all of this, I think that, we have to be aware that the sampling error is huge. So one thing I would say with these, I think, I don't know, okay, this is purely top of my head and my opinion. I'm not saying it's right. But maybe what we need to look carefully macroscopically, whether there's the idea of any microscopic capsular invasion is a toss of a coin. It's pure chance phenomenon, whether you find microscopic extracapsular invasion. It has to be a sampling phenomenon. And so idea that you can risk stratify patients, I don't think is entirely rational. But macroscopically, if you're finding an area that's irregular, that is likely to be extracapsular, yes, that would be worth sampling. It's again, as I said, it's a very imperfect one, but the best we can do. And I think we have to be pragmatic. That's my view.
Okay, Brendan, and then Dipti.
Yes. Sorry, I'll be making this point tomorrow, but so say in the head and neck, if you've got like a 5 centimeter, obviously metastatic mass, I think you can probably target the areas where you think the extracapsular spread is going to be, just to save you taking 20 odd blocks of this mass, just targeting. You can always go back as well.
Okay, Dipti.
So I wanted to hear from others, what is the approach for lymph nodes for benign cases? I'll tell you, for like benign GI cases, I just say to submit 1 block of lymph nodes. I do not need to see 12 blocks of lymph nodes for a
Absolutely.
benign Crohn's disease. What
Sure.
do others do?
Yeah, I don't ask them to go hunting. Whatever pops up, sample. And when sectioning, if there's something different or necrotic or something that catches the eye, then sample that. Otherwise, if it's
So
established.
Ranjan, once I got like 12 blocks of lymph node in a Crohn's disease because everything popped out. That's what the PA told me. I was like, why did you submit 12 blocks? And they were like, well, it was easy to submit.
Yeah,
And I
if you
was
use
like, well, it might.
you use Neil's procedure, you would have had only 2 blocks, right? But yeah, I think in that situation, you can put more in a block. But yeah, I think we oversample. There's no doubt, especially in North America. You know that we use PAs
Yeah.
and they
And that's the
oversample.
reason I tell them limit it to 1 block. I do not need to
Correct.
see more on a benign case.
Okay, Paramita, quickly, and then I just want to get there's some very interesting questions here from the audience, so I'd like
I
to
think
get
it's
to them.
same solution for palliative surgeries in cancer also. Why do extensive lymph node dissection if it's a palliative therapeutic?
Okay, so here's an interesting one, and I see Laura's on. Laura, this is for mastectomy specimens. I measure the gross resection deep margin on fresh, and then measure it again after fixation. Thoughts on that? There's a huge difference, according to Maram.
Well, I'll be talking about this later on,
Okay.
so I have a big discussion on
Perfect.
margins.
Okay.
So yeah, I mean, we do, just as standard practice, have the gross or the macroscopic measurement described, the distance to the margins in 6 dimensions. In mastectomies, it would only be in the anterior and posterior. And then, yeah, I mean, it needs to be confirmed microscopically. So we use the microscopic distance.
Great. Here's an intriguing one. Some insurance companies need the weight of the specimen, e.g. the uterus, in the report to calculate compensation. What do you think about that one, Murali?
Yeah, I think that's the point I think I made there. It's part of the gynecologist reimbursement. They got a 250-gram cutoff. So if the
Right.
uterus weighs more than 250 grams, the surgeon is paid more than a uterus weighing less than 250 grams. Now, this was just because they were taking it as a surrogate for the complexity of surgery. And so in those situations, yes, the pathologist would have to report the weight of the uterus. But my issue is when pathologists in the UK and other places where the weight has no relevance at all still record it.
Okay.
We've got
Yeah.
a couple of minutes, Ranjan, so I think we
Okay,
can take
let's-
a couple of quick
let's-
questions
let-
because we need
sure.
to then take a break.
Sure. I just want to, this is quite intriguing. Can a hospital or a pathologist force a surgeon, or can a surgeon force a pathologist to do on-call rota to come in to slice critical specimens on the weekends and after hours? What is the medical legal view on this?
For us, I suppose it would be more like what's the BMA view, if it is for a pathologist, or the IBMS view, if it is, BMS stuff. So, because this is more of a job planning question, isn't it, rather than a medical legal question?
Yeah, exactly.
As to whether you can.
I don't think there are any medical legal implications there, unless you
it's
unionize
entirely a
and
job planning
work
and the
to
payment.
rule. Yeah.
So it's a bit like exactly like Tesco asking people to work on Christmas Day.
Correct.
Right.
And there are a few slightly disparaging comments about the abilities of surgeons to slice specimens. Another one on clearing
I'm not
fluids.
surprised.
I think we all have horror stories locked away. Use of
But as I
carnoids.
said, but I think we can train. I believe they are educatable.
And then there's a couple of comments about cleaning the bowel contents before they slice into tumors, use of carnoids, clearing fluids. I think we pretty much covered most of that. So I think the specific questions will be addressed in the specific sessions, as Laura intimated, in breast and DIPT and GI, etc. So I would encourage everyone to attend those. Remember, you have to register individually for them. So please do. And again, the times are GMT, not BST. And I'd like to thank Murali for an amazing tour de force, as I said. And I'd like to thank all our discussants, for their contributions, insights, and personal glimpses. I think that's really invaluable to everyone listening, and I'm sure everyone learned a lot. So with that, I think I'll conclude this session. And
let me, to second what you said. Thanks very much both to the panelists and the attendees. The panelists have been brilliant. Okay, the discussion we had, the open debate, and the disagreements. So we were not trying to create an artificial consensus. So thank you very much for your contribution, Ranjan. Thank you for for chairing this session and moderating it. And lastly, I would reiterate what you said. You got 5 more webinars coming, and there will be a lot of crossover between. So you can ask some of these questions that were not answered here. You could ask in the other webinars too. Thank you all. If you're done, is Preeti here?
Yes, I'm here. Hi.
Yeah, Preeti, I think you would need